Welcome to today's office hours on smoother schedules. Start with smarter prior authorizations. I'm your fill-in host today, Lora Pada, VP of Customer Success here at Infinix, and I am joined with Danelle Newman, Director of Patient Access at OSS Health. Hi, Danelle.
Hey, everyone.
Great to see you. Before we get started, can you give us a little background on yourself, what your role is at OSS Health, how long you've been there?
Sure. Been here 13 years. Actually started in the rev cycle team. I was a rev cycle manager and then moved into patient access manager and have been the director of patient access for the last 3 years. I have authorization, all of our registrars, contact center, eligibility, benefits, all report up through me for all of our physician clinics, our 4 urgent cares. We have 2 ambulatory surgery centers, 2 pain centers, and a 30-bed orthopedic specialty hospital. We have 35, 36 providers and a bunch of APPs. So pretty large organization here in York County.
Nice. All right, so let's get started.
Great.
So can you kind of tell me what your current prior authorization process is internally? Like, when do you get an auth? How do you do it before the patient's scheduled, after the patient's scheduled? What's your kind of workflow?
Sure. So our patients come in through our physician clinics. The provider places an order. We have a scheduling department that will schedule those patients for imaging studies, surgical studies. And we have like an insurance guideline that we utilize. And we try to book our patients out usually like 5 to 7 days for imaging cases. Therapy typically is the same for evals. And then all of our surgical cases are typically 15 to 20 days, depending on the insurance, except if it was like an urgent or emergent add-on. We use those guidelines because we've found that the insurances will take as long as they possibly can to obtain and give us or provide us that authorization. It also gives us a little bit of a buffer if we have docs that are super duper busy and they don't finish their progress note when they're in with the patient. We sometimes have to wait for all the supporting documentation to be signed before we can upload that information. So we use a guideline to help our scheduling staff be able to.
So like payer based. So like, let's just say Blue Cross Blue Shield, we know we have to book 14 days out versus maybe like a Medicare, I could book within 24 hours, something like that, right?
100%. Like we know that in Aetna, if we're asking for a surgical authorization, Aetna will say they have 15 days to turn around and answer to us. So why put somebody on the OR in 10 days when you know Aetna is going to hold our feet to the fire to they have 15 days to complete it.
Right. And then last thing you want is a reschedule. But what happens if, even by using kind of the parameters that you built, like what happens if an auth isn't ready? So like time of service, date of service is in 3 days, it's not ready. How do you work
Yep.
around those?
We do have some workarounds for that. Depending on what the modality is, we have parameters around imaging cases. For example, what we will do is we will tell the patient that we don't have the authorization. Sometimes if we tell the patient, they can be an advocate for themselves and that they can call the insurance and be like, look, I'm scheduled tomorrow for this imaging, and advocate for themselves.
Does it usually actually work? Does that work if the patient actually calls itself?
Sometimes it does. We also communicate when we're telling the patients that, right? Patients call in on like a member services line and
Yeah.
Highmark, for example, or Capital Blue Cross, right? Their goal is to like make the member happy on that call, right? So members, the patients calling in saying like, look, I'm scheduled for this. They really need to get to somebody on the authorization team. Talking to just a general customer service person isn't going to get them where they need to go. So we kind of coach them if they are going to advocate for themselves to do that. And then we have a process in place where we have like what we would call like a wait list. So we have patients who maybe are scheduled, like today's Thursday, right? Let's say we have patients that are scheduled for Monday and we've already have their auth on file. When we're scheduling those patients for that service, we'll say to them, hey, if we have an opportunity and get the authorization prior to your Monday appointment, would you be open to or receptive to coming in early? And typically some patients will say yes. There's some patients that say no just because they need to worry about transportation or they need to request off work, those types of things. We use that as an ability to, it's also a patient satisfier. If we call the patient, they were thinking that they couldn't come until Monday, and we call them up in
Hmm.
the afternoon and say, hey, we can get you in tonight at 5 o'clock, right? Because we have cancer. Or hey, we can get you in tomorrow. That's a win-win for us, right? The patient,
Right.
like it's we've made it an awesome experience instead of like a stellar, right?
Hmm.
You do that. We do the same thing for our surgical cases, specifically spine cases. Spine cases are docs, these are longer cases. We definitely do not want to have an open OR, right? So we really look closely at our optimization and how do we optimize that OR time and having wait lists for patients that we already have been able to obtain that authorization quicker than we expected. Um, we use where we don't have an authorization for somebody as an opportunity to say, hey, let's move up this patient and get them into the OR quicker.
Yeah, that's a great idea. I've heard that from a lot of customers too. They have this wait list, especially for imaging orders, because like last thing you want to have is like an open slot that you can't fill for an MRI, CT, because there's seems to be, a lot of reschedules more so on the imaging side.
There's also a sweet spot too. If we own our own CT and MRI scanners, right?
Mm,
Sweet spot of you want to be booked out 1 or 2 weeks, right? You don't want to
right.
be out 2 months, right? Because patients that the imaging is needed to be able to have their follow up to schedule their surgery or to be able to determine what's going on. That's the diagnostic test, right? So a sweet spot of how far do you want to be booked out? Do you want to be booked out 2 weeks? Do you want to have set slots every day for urgents and stats? And so that sweet spot is really important, and having that wait list to fill in those little gaps is very very integral and is a positive for our revenue.
Yeah. Yeah. I totally agree on the wait list part. At a high level, like how are prior authorization challenges showing up like before the day of service? Again, I know we talked about this, the auth isn't ready. But how's that affecting your staff, maybe your doctors?
The challenges with prior authorizations is that you have to play the game with the insurances, right? So
Yeah.
insurances typically have med policies that they follow in regards to, especially total joints, the certain conservative treatment. They have to have physical therapy for 6 weeks, maybe 12 weeks, once or twice a week. They won't take home exercises. So the challenge is staying on top of those medical policies and really playing that game. So right now, if you know that Capital Blue Cross isn't going to let somebody who has a BMI over 40 have a total knee replacement until they've had a weight loss discussion or they've lost 10% of their weight, those are things that we try to capture before we book that patient for the surgical case. So we'll say to the patient, hey, we know that Capital has these requirements. You haven't had physical therapy. You need to go to physical therapy. Sometimes our patients will say, hey, they don't want to. Well, you know what? You have to be evaluated from that. We provide really good feedback from our utilization department to our provider teams that if they're missing that from progress notes, that they need to put that in those notes, right? Because we're playing the game. But we're going to submit it,
Yeah.
put somebody on the case, right? 20 days from now for surgery. They don't have all the completed documentation in their progress note. We ask Aetna, for example, right? Talked about their 15 days. We ask Aetna, hey, we want an offer of total knee. Aetna comes back in 15 days and says, no, you're not going to get it, right? Because you didn't do this, this, and this, and it's in our med policy. Now we have to start over, right? So we try to do as much as we can to play that game, stay on top of those policies. We really look at those quarterly. And
Quarterly. I was going to ask you, how frequently do you look at them? Is it for all payers or just your major payers?
no, I mean our top probably 7 to 10 payers, we're looking at those quarterly, right? They send us
Okay.
bulletins, right? But
Hmm.
you know that those bulletins are 40 pages long, or it's like in an email that you're trying to weed through. So we specifically go out to, our high ticket or the cases that we do on a regular basis and really look to see where's that med policy, when was the last day that it was revised. And again, like I just go back to, we have to play the game with them, right?
Yeah. I mean, does your back end talk to your front end? So, for example, sometimes like a lot of our customers don't check the med policies quarterly, even yearly. Sometimes it doesn't happen. Then they start to see the denials on the back end, and they're like, well, why aren't you getting authorizations? It's missing an auth. That's a denial code. Are you guys talking and kind of like changing, or is that forcing you guys to change your workflows?
It does. It does. We do talk. We have actually a biweekly meeting with our back end to look at those denials and track and trend. Are we seeing something new? That's another area where we see, oh, look at what they're doing because they flipped the switch on us on this, right?
Yeah.
Sometimes we can go back and be like, no, this is what your med policy says. Um,
Yeah.
but yeah, so we again is another area of right now they're denying for this. In 3 months they're going to be denying for that. They're always trying to find some way to not pay for the members' services, right? Like,
Yep.
they're
Hmm. It's a
the
game. It's such a game.
are paying all these high premiums and they will find every possible way to say no, right?
Yep.
And I
Yep.
get that there
Yep.
needs to be clinical documentation, right? And warranted surgeries, but some of these insurance companies really are really going out of the way to inhibit patients from having services rendered that they out of required.
Yep. Totally understand that. And I mean, we see this across the board. So you and I were at AOE a couple weeks ago. And one of the things that came up in a lot of the talks that I had and like just listening into some pain points was that during, especially for surgeries, right? The surgeon goes in, you have a list of CPT codes that were approved. Then the day of the surgery, something changes, right? And all of a sudden the CPT code changes. And then maybe the doctor doesn't communicate, it doesn't upload their notes. And then you end up having a write off because you didn't get that retro or new off. Like, how do you guys do that internally? What's your process?
Feel the pain. It's a challenge
Mhm.
for all of us, right? Some of the things that we have implemented is that we provide an actual printout of the schedule for each of those providers that says, this is what you said you're going to do. These are the CPTs. And they have that available to them the day that they're in the OR. Um,
Okay.
they know that if I said I'm going to do this and I'm doing something different, that they have to articulate to the circulating nurse, hey, this isn't what happened. The second thing that we do is we've asked when they are acknowledging that something happened that was different, the circulating nurse then can communicate to all the different departments and be like, hey, we need to act on this today, right? Because there's a lot of carriers that won't let you make any adjustments the day after, and then you have to file the claim and get a denial and file an appeal. But the other piece that we have instituted with our providers is that when they are dictating their op report, that they need to speak to the why. This is what I intended to do, and this is actually what I did, and the why. And that has been helpful because docs weren't doing that. They were just dictating their op note, this is what I did. They
All
weren't
right.
in their op note as to this is what my intention was. I knew and I communicated to the patient that possibly I'm going to do this, right? Because a lot of times they know that there's something when they open the patient up, they're going to be like, I might have to do that. We typically do talk to the patient about that because we need to have the consent for us to proceed, right? So we have
Hmm.
it on the front end in that this could be what happens. But that op note is really, really important for us to have them really specify what they intended to do and what they had to do. And we have them complete that right then and there for those patients so that we can use that op note to be able to submit that or call Highmark and say, hey, inoperatively today, this is what the intention was, but this is what we did. We need to update this on.
So doctor comes out, provides a checklist, makes any notes, gives the whys. Then what happens? You give to someone internally and they go ahead and call the payer, or
Yeah, the
is that
circuit
usually the
nurse
case?
that will communicate to our back end, utilization and to the off team. So when I say the back end, I'm saying what they're going to do is they're going to put a hold on that claim. They don't want to. They typically our system, right? If everything is done, the bill will drop next day, right? So what they do is they put a hold on that claim because they don't want the bill to go out with an authorization that maybe isn't updated, or they might change the auth number, or maybe they're adding additional codes. So we fire that off to the billing department so that they can put a hold on the claims, the professional and the facility claims. The off team then gets on the phone to the carriers immediately and says, hey, this is what we need to do. We're changing this inoperatively. Some carriers will obtain or give us a new authorization. Sometimes the carriers will still say, no, we're not going to do anything different. Submit the claim, send your op note with the claim, some of those types of things. But that's our current internal process. Sometimes we do,
Okay.
sometimes we don't, but it is a challenge, I think, with every orthopedic group.
Yeah, orthopedics, all specialties, I would think. I mean, this just looks like it's a constant. It's just, but I mean, because sometimes they actually payers will say this is considered a retro, right? And like you only have 24 hours to make the change, and they have these timely filings, so it's like it's payer dependent as well. Some of them have maybe give you 30 days to make the change, but usually it's a pretty tight timeline that you have to go back and re-auth it.
Again,
So
play fair game, right? We're
exactly.
every possible way to win at the game.
Yeah. And then that's also staffing issues too. If you don't have the people there, you don't have any backup support, then that's just like, it's almost
Yeah.
like an automatic write off.
Yeah. And these are high ticket items, right? We
Right.
got, right? We're still,
Yeah.
we're an independent practice, if we're profit, so this surgeries is our bread and butter. So,
Yeah.
and I think that everybody else can relate to that as well, right? We have to be able to get these paid for us, and we don't want the patient to have such a bill.
Right. That's the worst. So like from your experience, what should organizations focus on first if they want to reduce those preventable cancellations? Um, Anything that you like proactively, anything that your team does, is it patient reminders, anything at all that's helping make sure that these don't get canceled?
That's a great patient reminders is something that is awesome that you said that. What we do is everybody that's scheduled for a surgery, they typically are coming in for an H&P pre-surgery appointment at some point within 30 days prior to their services being rendered. So two different things that we do. When they come in for their H&P, the registrars really are specifically saying, hey, Laura, I just, you're scheduled for surgery the end of this month. Was there any changes? Do you still have Capital Blue Cross? Or did your employer did you have an open enrollment opportunity, and is your insurance going to be changing? A lot of times we win on that in December and January because of all the changes.
Re-verifications, yeah.
The other thing that we also do is we send out a reminder, like we call it a broadcast message, and we send a phone call and a text message to all of our patients that have upcoming procedures, whether it's a pain procedure, a surgery procedure, and we say to them, it comes 30 days in advance. Hey, you're scheduled for a procedure. If you have any changes to your insurance in the next 30 days, please contact us, right? Because we see where patients just assume that they forget, right? They get a new insurance card and they forget to tell us, or you go to the pharmacy to pick up your prescription and the pharmacy says, oh yeah, like this didn't go through. You're like, oh yeah, I got a new insurance card and never gave it. So this is a way for us to kind of ping them as a reminder and be like, hey, cue you in, and in that notification we say, if you've had new insurance and you don't notify us, there is a possibility that this procedure will be canceled. So that's one of the things that we do.
Well, what about checking eligibility benefits then? So it's like you do it obviously with the patient schedule, but how many times before the actual surgery is done? Do you do it the day before? Do you re-verify?
Yep. So when the patient's originally in the clinic and the decision for surgery is made, that we checked eligibility for that office visit. We also check eligibility and benefits again when they come in for their H&P or their pre-surgery appointment. And then we do a final check. Typically what I say the old days, like chart prep, right? The day prior, to make sure that there isn't any changes in their insurance, especially, and then we always do the first of the month. So MA plans, we check daily. So if I'm a patient and I'm on a medical assistance plan, I could have been
Hmm.
on yesterday and I could have changed to a different managed care plan today. So those are
Oh,
the same day.
yeah.
As again, it's typically not going to change with a commercial plan on the 7th or the 8th of the month unless the patient is terminated from employment and it's from their last date of employment. But typically we check MAs the same date of service. Everything else is typically last check is the day before.
Okay, so you're doing it multiple times actually just to catch this prior to, especially a surgery. I understand. Yeah, that's a good point. Like what, but from the, I'm sure you hear a lot of patient complaints in your department. But from the patient perspective, even just from an organizational, like what's the real cost of a delayed or rescheduled procedure? Like I understand the impact on like, but what do you hear?
Right.
And how do you try to kind of, educate them as well on what they can do to make sure that there are no delays?
100%, right? Like again, the date of the decision for surgery, we kind of talk through that with those patients, and a lot of them again are going to need a driver. They need to think about what their
Yeah.
house leaves look like. They maybe have to fill out disability forms for their employer. Like how important it is for the patient to recognize and understand that, right? If this cancels, if this blows everything to the water, right? Now the patient was expected to be off for 6 weeks, and their manager thought that they were going to be out starting tomorrow, and now the case canceled, we might not be able to get them back on for 4 or 5 weeks, right? If it's an urgent or acute, maybe it's a couple days, right? But we those situations do happen. We also, if we come down to the wire and a patient is super duper adamant that they want to proceed, we'll provide them with a self-pay amount, right? We have had in some cases where patients are like, I'm going to proceed. I'll pay the self-pay bundle rate and I'll fight it back on the back end. We don't see it very often, but it does happen. Specifically, I would say more so for imaging cases where the patient is frustrated that their insurance isn't doing what they're supposed to do, and they'll say, you know what, I'm just going to pay for this and I'll argue it on the back end, which I'm fine with, right? We have our money. They signed a waiver that they agree to be self-pay, and we can proceed.
Actually, I'm going to go on a tangent here with self-pay. Do
Yeah.
you see that a lot with maybe when you're scheduling, they schedule as a self-pay, or that they maybe have, and then they come at the time of service with their insurance card? Yeah. How does that work?
We see that when they come into our urgent care centers, right? They come in through our urgent care center, they say that they're self-pay, and then when they come for imaging, that is what happens. And again, at that point, we say, hey, when you came in for your urgent care visit, you are self-pay. If you want to utilize this Highmark for the MRI today, your option is we're going to reschedule you, or we're going to ask you to pay the self-pay rate.
But what about I've heard also just from customers like saying that sometimes their self-pay rates are a lot lower than what they'd have to pay commercial. So it's almost like they're playing the system as well, because if you give them a pay rate, obviously it's a little bit cheaper because you don't have to go through the whole payer process. But at what point do you like, well, is there any policies in place? Do you have a self-pay policy, or do you run it through anything to verify that they have no commercial? Like, how does that work at OSS?
We do not verify or run it through anything to see if they have any commercial plans. So if the
Okay.
doesn't present with insurance and they say that they're going to be self-pay, that's on them. And yes, our self-pay rates are decent, right? Like sometimes it does
Mhm.
make sense for patients, especially if you have like a high deductible health plan, and you know that your plan is going to that you're going to have a new enrollment time in June and it's May, and you have to have an MRI. If the full thing is going to go to your deductible and the charge was $1,200 and 600 of it was going to be applicable to your deductible, if the self-pay rate for an MRI is 450, the patients typically will roll the dice and they'll say, you know what, I'll just pay the self-pay rate. I can get in faster. You're not gonna make me wait 5 to 7 days for me to get an authorization. Chances
Yeah.
that I'll fit you in the next 2 or 3 days in one of those open slots, or the ones that we're holding for somebody. It can be a win-win for an organization, but we do have our patients sign an agreement that says you're choosing to be self-pay. You can't come back and present insurance and ask us to try to attempt to get a retro authorization for you. So that's kind of
Okay. So do you ever see it though? Like, let's say they come as self-pay, maybe it's an MRI, X-ray, they're just going to pay the lower rate. But then let's say they have to have a procedure done.
yep.
And then is it,
Bring out the card, right? And they
yeah.
can bring
Mhm.
they can bring out the card. My hope is that they don't wait till the day of the surgery to bring out the card, right? Sometimes they'll articulate, you know what, I'm just going to run this through. I'm going to pay self-pay for this. If this comes back that I'm going to need surgery, then I'll give you my Highmark or whatever. But we don't typically, again, the beginning of the year is sometimes where we'll see a patient come in, they came for their
Yeah, resets. Exactly.
and those are the deals where it is uncomfortable conversation for registrars to have. But if you were on a Medicare plan that was that required an authorization and you changed to another Medicare plan, that off from the plan you had in 2025 is not going to count for the procedure you're having done on January 3rd. So, we really try to do as much as we can on those, but everybody's going to have some of those cases where
Yeah. I
okay,
don't think there's a way to avoid them. I mean, I've heard some people say, well, we're going to raise our self pay. We realize that this is happening more frequently than not, especially on imaging orders. So we're going to make it a little bit more comparable, but then you have to worry about them going somewhere else. So it's a tough battle, right? Don't just go to a competitor who will take a lower self pay rates or not going to be as nitpicky about it. So it's hard to balance.
yeah.
We have only a couple minutes left. I'm going to open this up to see if there's any questions in the chat for us. If there's any questions, please go ahead and drop them in. I do see one. Um, what are practical ways teams can identify risks earlier before they impact the schedule? Any advice on that?
Practical ways they can identify.
That can identify risks earlier before they impact the schedule? Anything that your team does just to kind of be more proactive? Any?
I think part of that goes back to coaching our clinical teams and our providers on some of the requirements that for I'm going to talk about total joints, for example, right? We built in our progress notes for our clinical teams a button that says like prior treatment that therapy, right? It cues them in that they have got to document what the therapy is. If the patient has a BMI that's over 40, they know that the doc has got to have a conversation with that patient that day. So we've kind of communicated or educated some of those commercial policies or med policies around total joints to be able to communicate that back to the provider. So that's kind of one of the ways that we've been proactive in don't even don't even have the conversation about surgery, right? Say, here's some things we know that your insurance is going to require. We got to do this, this, and this. I'm not sure if that answers your question.
Yeah, actually, that's good. So it's like you're also educating the patient as well. Like, hey, in order for this to happen, you're also responsible. It's not only just put on our hands. Like, there's stuff that you could help us do it with. So that makes a lot of sense. Let me see if there's any more. No, I think this kind of just the other question is very similar to what we've already covered. So I'll kind of leave it at that. Well, thank you for joining today, Danelle. Appreciate having you on. Some really good
Oh,
information.
great. I hope it was informative for those that are attending as well.
Yeah, absolutely. All right. Thank you for your time.
Thank you.